After 8, and it's our pleasure to have Dr. Amanda Vinson from Dalhousie University to talk to us on sex differences in access to and outcomes after transplantation. Dr. Vinson is a transplant nephrologist at Dalhousie. She actually did her med school in UBC and then moved to the Maritimes to do her internal medicine and nephrology fellowship, and then go back because she loved it there. She's also done a master's in epidemiology from Boston. She has funding from various agencies, including she's a Crescent new investigator awardee. Some of you may have heard her at the TED Talks at the CSN, but we'll have a longer version today where she'll be talking about sex differences in access to and outcomes after transplantation. So go ahead, Dr. Vinson, welcome.
Thank you so much for the opportunity to be here today. And I'll let everyone know I can't see anyone in the chat. I can only see my slides, and my head-on camera is not working. So you're going to get my profile for this talk. So I apologize for that. My talk is entitled Sex and/or Gender Differences in Access to and Outcomes After Transplantation. I do have some disclosures. I have received some consultancy. I've done some consultancy work for Paladin Labs, and I've received fellowship grant funding through Paladin Labs, but for studies unrelated to what I'm talking about today. In addition, I have some additional disclosures in that a lot of the data I'm going to be presenting is incomplete in various stages of peer review. And as Swapnil said, I presented a similar talk at the CSN 2 weeks ago. And so if you saw that talk, some of the slides are going to look familiar to you, but hopefully a bit more detail in this time around. So the objectives are to talk about sex and/or gender differences in transplant access, transplant outcomes, and then COVID-19 in transplant patients. But before we can have a talk about sex and gender, it's important to go over a few definitions. So this infographic is from the CIHR website directly, and it defines sex and gender. Gender is a social construct defined by behaviors and roles and identities. And when we talk about gender, we're generally referring to the terms like men, women, or feminine, or typically masculine behaviors. But there's not just two genders. Gender is a spectrum, and you can fall anywhere on that spectrum based on how you identify. Conversely, sex is a biological variable made up of biological factors like chromosomes and hormones and genetics and epigenetics. And so throughout this talk, I'll be using terms like female, women, male, men, interchangeably. And the reason is because really, when we talk about outcomes related to sex and/or gender, ultimately, probably both of these factors are playing a role. We don't really know whether it's sex and/or gender that's the issue. So I will be using these terms interchangeably. Now let's talk about transplant access. Now we know that women, at least in the United States, are less likely than men to be transplanted. In the United States, women are less likely to be referred for a kidney transplant, to be activated on the wait list once they're referred, and to undergo transplant once they're activated. However, contemporary Canadian data on gender disparities in access to kidney transplant are lacking. So you might say, like that's the United States. They do a lot of things differently there. What does this mean for us? Like, what about us? Well, interestingly, we don't have data from across Canada at this point. We're working on that, but I do have some numbers to share with you for Atlantic Canada over the last decade. So of the 719 transplants that took place, 66.8% of those kidneys went to a man. So more than twice as many men than women were transplanted. So is this a problem? Like, should we be concerned about this? Well, if we want to talk about number of transplants, it's important that we think about that in the context of who's developing end-stage kidney disease. So if we look at the people developing end-stage kidney disease over the same time period in Atlantic Canada, 60.4% of people new to dialysis were also a man. So a little bit more parity when we look at what's happening in terms of transplant numbers. So, is there even a problem? Well, with a bit more granularity, we can look at data from Nova Scotia over the same 10-year period. So we know that in order to be transplanted, you need to be activated on a wait list. In order to be activated, you need to be referred. And in order to be referred, you need to have end-stage kidney disease. So if we look at the number of men and women who have end-stage kidney disease in Nova Scotia over this time period, if you were a man, you were 1.23 times as likely to be referred for a kidney transplant than if you were a woman. If you were referred, you were 1.05 times as likely to be activated and 0.98 times as likely to be transplanted. So if we take this information together, if you were living in Nova Scotia from 2010 to 2020 and you developed end-stage kidney disease and you were a man, you were 1.28 times more likely than a woman to be transplanted. So this to me is quite concerning. And if we think about kind of where the biggest issue is, clearly it's in differential referral rates. So what might drive differences in referral rates? Well, maybe it's true differences in eligibility. Maybe it's differences in provider assessment of eligibility, or potentially it's differences in patient perception and self-advocacy. So let's go through each of these separately. So what about true differences in eligibility? Well, I just showed you this slide, but actually it's not the denominator of patients with end-stage kidney disease that we need to be worried about or need to be considering. It's actually those with end-stage kidney disease who lack an absolute contraindication to kidney transplant, so far as they don't have something that would make them ineligible for a transplant. So if we look at all patients who have end-stage kidney disease, men were 1.28 times more likely to be transplanted than a woman. But perhaps if we look at a subset of patients who lack an absolute contraindication to kidney transplant, there's more parity in the referral rates between men and women. So I have some preliminary data to share. So we looked at all patients from 2010 to 2020 in Nova Scotia with end-stage kidney disease, and we identified patients who had an absolute contraindication as defined by our program, acknowledging that no contraindication is really absolute, and different provinces and different programs have different criteria. But in our center, if you're over 76 years or you have a BMI more than 40, you are not eligible for a kidney transplant. So when we looked at patients who had end-stage kidney disease and identified these transplant contraindications, we saw that there was actually surprisingly an equal number of transplant contraindications for men and women. 41% of women with end-stage kidney disease had one of these, quotation, absolute contraindications to transplant versus 42% of men. So if we look at what's remaining, the population of patients who were potentially eligible for kidney transplant, insofar as, again, they lacked one of these absolute contraindications, 75% of women were referred for a transplant versus 84% of men. And this was statistically significantly different. So you might say, why weren't 100% of people referred if they lacked an absolute contraindication to transplant? And I would actually say the same thing. So that's another issue for another day. So this study is ongoing. Basically, what we're looking for at this point is main drivers of gender disparate referral. For example, I showed you a list of absolute contraindications to transplant, but ultimately we want to identify if the contraindications that are observed in the females are that every woman who's starting dialysis who has an absolute contraindication is 85 years of age. That's not going to get better over time. But if the men have a contraindication from transplant in such that when they start dialysis, their BMI is 40, and over 2 or 3 years, they're able to lose weight and then subsequently become eligible for transplant, maybe that would explain the differences we're seeing. So we're looking into what exactly is going on. And then subsequently, we want to identify predictors of referral within 1 year from end-stage kidney disease, and then timely activation within 1 year from referral. So we'll change gears a little bit and talk now about potential differences in provider assessment of eligibility. So one of the potential barriers to transplant might be differential perceptions of frailty in men and women. We know that patient frailty could lead to transplant non-referral. We also know that frailty objectively is more common in women than men of the same age, and that the implications of frailty differ by gender and or sex, with frail men having a mortality rate that's 2.6-fold higher than frail women. Additionally, newer literature is suggesting that frailty is actually not static and can be improved with a kidney transplant in a subset of patients. So the question we wanted to ask was, does the perception of frailty differ for men and women? And also, does frailty associate with outcomes post-transplant or outcomes on the transplant wait list? So I have some preliminary data to share here as well. Many of you may know my colleague and my beach volleyball partner, Karthik Teningpur, who's doing a study examining frailty on the transplant wait list. We have data from over a 5-year period from 6 Canadian transplant centers, whereby when patients were referred for a kidney transplant, they had 3 frailty metrics. They had frailty assessed by 3 metrics: 2 objective metrics, the frailty phenotype and the frailty index, and 1 somewhat subjective measure, the clinical frailty scale. When we looked, I wanted to highlight here that these are patients who were referred for a kidney transplant. So this is obviously a little bit of a biased sample insofar as someone felt that these patients, despite their level of frailty, were likely potentially eligible for a kidney transplant. So this data does not include anyone who was felt to be, for example, too frail for a kidney transplant. So it's a little bit of a biased sample. However, when we look at gender difference in the prevalence of objective frailty in men and women who were referred for a kidney transplant, there was no difference. Men and women were equally objectively frail, as defined by the frailty phenotype and the frailty index. However, women were noted to be significantly higher, have significantly more frailty when defined by a subjective metric, the clinical frailty scale. So although objectively there was no difference in frailty scores by these frailty phenotype or the frailty index in men and women, women were subjectively felt to be more frail. So I'm told that Survivor is not that popular anymore, but if anyone does know Survivor, you'll know that one of the things Jeff Probst always says is that perception is reality. And the question is perception really reality? So in the subset of patients who were subsequently activated on the transplant waitlist, 325 patients, the association of subjective frailty with death or withdrawal was significant for men. So if we looked at a man and we said, you seem like you're frail, 2.59 hazard ratio that patient is going to be withdrawn from the waitlist or die on the waitlist. However, it was not significant for women. So if we looked at a woman and said, you look pretty frail, that actually had no association with death or withdrawal on the transplant waitlist. So William Shakespeare wrote in the first act of Hamlet in 1599, "Frailty, thy name is woman." So ultimately, we've been labeling women as frail for 400 or more years. But even in a modern era, women are being subjectively misclassified as frail. Interestingly, women who are considered subjectively frail are actually not at risk for adverse outcomes on our transplant waitlist. So is it possible, remember I said this is a biased sample of people who were referred for transplant, is it possible that subjective bedside frailty assessments are leading to non-referral in women? I think it is possible, and this is something that we're looking into. So I hope to have more data for you in the coming year. So let's change gears a little bit and talk about differences in provider assessment of eligibility. So you may have recently done or seen a survey that was distributed through the CSN and the CST, or if I know you or you know one of my colleagues, you might have received a lot of annoying emails from us asking you to complete this survey. It was 25 theoretical cases of 12 female and 13 male patients with end-stage kidney disease and complicated medical histories. And the question was, would you refer this patient for transplant or not? But actually, it wasn't one survey. It was actually two identical surveys, with the only difference between the surveys being opposite gender or gender pronouns that were used, with the obvious question here being, would referral rates differ by candidate gender? This study is also a work in progress, unfortunately, but I do have some preliminary data to share. There were 97 surveys completed, and overall, the referral rate was 60.5% for these complicated patient cases. And I'm very happy to say that the referral rate for the male and female cases was nearly identical. So it does not appear as we have a provider bias against, a gender bias against referral for kidney transplant patients in Canada, or at least amongst those who completed this survey. So great job. There were, however, two cases where there was a significant difference in referral rates by gender. So the case where the male case was more likely to be referred was a 73-year-old man with mild cognitive impairment and a supportive spouse. In this situation, 44% of the male cases were referred versus only 30.6% of the female cases, and this was significant. Conversely, there was one case where a female was more likely to be referred for a transplant, and it was a 50-year-old woman with a systolic blood pressure in the 80 to 95 range with a unremarkable cardiac workup, including an echocardiogram. And in this situation, 87.8% of male cases were referred versus only 97.9% of female cases. Again, this is statistically significant. Now, this is preliminary data again, so we didn't account for repeat testing, and it's possible that these cases differed by chance alone. But if I think about it, I guess I can kind of rationalize why we're seeing this difference. So we know literature suggests that people who have a female caregiver at home have better health outcomes. So if I think about this 73-year-old man with mild to moderate cognitive impairment, maybe I can picture his wife at home helping out with medications and helping him make sure he takes his immunosuppression on time. And for the female case, if I think about what I see in the dialysis unit, it's not uncommon for me to see female patients who are healthy with blood pressures in the low 90s, and a little bit less common for me to see healthy men with blood pressure in the low 90s. So I guess I can kind of rationalize what we're seeing. But also, maybe that's my bias showing. Even as someone who has research and an interest in gender equity and transplant access, I think we need to always be aware of our potential cognitive biases that might be there subconsciously. So just being aware, I think, is important. Okay, so let's move on to differences in patient perception and self-advocacy. There was a 1998 US study of incident dialysis patients that showed women were less likely to be interested in a transplant and less likely to complete the pre-transplant workup than their male counterparts. A similar study has not been performed since, nor ever in a Canadian context. So we know that compared with men, women, at least at a population level, have been shown to be less self-advocating in things like business, academia, and healthcare. Women report more health-related and psychosocial concerns regarding future kidney transplant. They're less likely to discuss kidney transplant with their healthcare provider. and are more likely to report experiencing gender-based discrimination in the transplant referral process. And all this data is out of the United States. Whether attitudes towards kidney transplant vary by gender in a contemporary Canadian cohort and how this might impact referral for transplant is unknown. So I'm happy to say that I recently received KFLC funding in the spring for a study entitled Gender-Based Barriers to Referral for Kidney Transplantation in Canada, the Patient's Perspective. The study will identify major themes and perceptions towards kidney transplant, will identify major gender-based differences in perceptions, if such things exist, and then we'll determine how differences in perceptions may associate with timely access to kidney transplant. The study will be done in 3 phases, with phase 1 being focus group discussions amongst incident dialysis patients, doing a thematic analysis to identify major themes. For example, guilt about receiving a kidney transplant or fear of the operation. In phase 2, we'll create questionnaires to examine each of these themes, likely approximately 5 questions per theme on a Likert scale from absent to present, to identify whether there are significant gender-based differences in response rates. And then finally, in phase 3, we'll examine how differences in perspectives associate with timely kidney transplant access overall and then by gender, with the primary outcome being referral rates in less than 1 year from dialysis initiation, and the secondary outcome being completion of the kidney transplant workup in less than 1 year from referral date. The goal of this research will be to ensure equitable access to transplant for all Canadians, regardless of gender. Remember that in the United States, men are 20% more likely to receive a kidney transplant than women, but even worse, in my own province, men are 28% more likely to receive a kidney transplant than women are. So if significant differences in perspectives are noted and vary by gender that associate with referral rates, perhaps this could prompt creation of patient and healthcare provider education programs, maybe patient engagement strategies, or potentially strategies to help navigate and complete the medical evaluation required for kidney transplant activation, depending on what the barrier is. So there are 11 sites who have agreed to participate in this study, including Ottawa. So Dr. Canny, thank you for agreeing to be a co-investigator on this study. So you guys in Ottawa might be seeing more of this study in your incident dialysis patients. Okay, this study is obviously very early, and hopefully I'll have more information for you in the coming few years. So in summary, women appear to face significant disparities across in access to kidney transplant worldwide, including in Atlantic Canada. It appears that the biggest barrier is at the referral level, and we're doing ongoing work to identify why that is. The issue being, of course, that we want to identify what those barriers are, whether it's differences impacting referral rates, activation, or transplantation itself, so that we can identify those barriers and then overcome them. Okay, let's change gears a little bit and talk about sex and/or gender differences in transplant outcomes. So we know that women have better graft survival, or do they? So this is data from as recently as 2013, looking at outcomes by the sex or gender of the recipient. And ultimately what we're told is that females have better overall graft survival. But this is likely an oversimplification, because when we're talking about the implications of sex in kidney transplantation, we need to consider the modifying effect of donor sex. So let's take into consideration donor sex. So again, same authors, 2013. It looks like if you're a female, you're still going to have overall better graft survival than if you're a male. The outcome here is cumulative graft survival. You're going to have overall graft survival than if you're a male, irrespective of the sex of the donor. Okay, so maybe this is the story. But ultimately, this is also an oversimplification. We know that men are generally larger than women. This puts greater demand on the transplanted kidney, particularly when the donor is a smaller female. And we see that in, no matter how you look at it, in most cases, if you don't adjust for weight mismatch between the donor and the recipient, a female donor giving a kidney to a male recipient usually has the worst outcome. So to better address that, this is a study, this is actually the first big study I wrote in 2017. It was looking at the combined effect of donor size and sex mismatch. So you can see here, I'm not sure if you can see my pointer, but you can see male donor, male recipient, female donor, female recipient, male donor, female recipient, and female male donor, male recipient. And within each potential donor recipient sex pairing, what you can appreciate is a graduated increased risk of death-censored graft loss as the recipient size increases relative to the donor. The thought here being that this is reflecting increased hyperfiltration risk and subsequent hyperfiltration injury when the recipient is larger than the donor. But what you can also appreciate is the biggest risk overall was in the combined setting of size and sex mismatch. So in the setting of a female recipient of a male donor kidney, the thought is that this reflects the HY antigen effect. So HY antigens are minor histocompatibility antigens present on the Y chromosome, of male organs that females are otherwise naive to. In the setting of a male recipient of a female donor kidney, the increased risk is felt to represent exacerbation of nephron underdosing, with a greater metabolic demand in male recipients and smaller female donor kidneys with having fewer nephrons per unit mass than male kidneys. So perhaps in the setting of a female recipient of male donor kidney, we're seeing increased rejection risk on account of this increased HY antigen effect. And in the setting of a male recipient of female donor kidneys, we're seeing exacerbation of nephron underdosing. So this must explain what's going on. But actually, this is also an oversimplification. Whenever we talk about the implications of sex in kidney transplantation, we need to talk about the elephant in the room, and that's the impact of sex hormones. So we know that estrogens are immune stimulating. This can lead to an increased risk of an increased immune response and increased rejection risk in female transplant recipients. Conversely, while testosterone is immune suppressing, it can lead to an increased ischemic response and an increased risk of delayed graft function in male transplant recipients. But there's more still. We know that sex hormones change over an individual's lifespan. So if we're saying that estrogens are responsible for an increased rejection risk in female patients, it's likely not fair to compare the immune risk in a 35-year-old female whose estrogen levels are at peak to a 65-year-old female whose estrogen levels have become suppressed. So ultimately, when we talk about the implications of recipient sex in kidney transplantation, we need to think of three main things. Firstly, the recipient sex, but we also need to consider the modifying effects of donor sex and recipient current age as a marker of what's going on with sex hormone status. And in addition, we should always consider weight mismatch. So this is a study I recently published with Beth Foster out of McGill, Dr. Foster. It was an IPD meta-analysis combining data from the SRTR, the ANS data, and the CTS registries for nearly 440,000 individual patient encounters. And we examined the pooled female versus male recipient hazard ratio, stratified by donor sex, and recipient current age. Again, that current age factor being there as a sort of a surrogate marker of what's going on with the hormonal status in the patient, in the male and female recipients. So this is an example of the data this is an example of our results. So we examined female versus male recipient risk in male donors and then separately in female donors, stratified by recipient current age, so the age at which an event occurred. And we looked separately at the female versus male risk in each of these registries, the SRTR, the CTS, and the ANS data, and came up with a pooled risk in female versus male recipients in male donors and then subsequently in female donors. And what you can appreciate is that when the donor is male, female recipients are higher risk for this Dalhousie death sentence or graft loss when they're younger. That risk diminishes with advancing age, such that after 60 years of age, female recipients are actually lower risk for graft loss. So if we pool the results from the three registries and into a summary slide here, you can see that we have the hazard ratio in female versus male recipients, stratified by recipient current age, so the age at which the event happened, in male donors, which are the black diamonds, and in female donors, which are the gray diamonds. And ultimately, what you can appreciate is that when the donor is female, there are no sex differences in younger recipients. When the donor is male, there's a higher risk in younger female recipients, and irrespective of donor sex, the risk is lowest in older female recipients. So there's a lot of reasons why this might be. A lot of factors are at play here, both sex and gender differences. But ultimately, we explained our results primarily on the basis of this HY antigen effect, leading to an increased immune reaction in female recipients of male donor kidneys, leading to this increased risk that's observed in the setting of a male donor, but also the changing hormonal status, leading to an increased risk in earlier premenopausal female patients. What about sex differences in patient survival post-kidney transplant? Well, this is data from the Eurotransplant Senior Program, which is a program in Europe looking to find older kidneys for older adults to try and get these older patients transplanted quicker. So all donors and recipients here are more than 65 years of age. But what you can see very clearly is that there's a clear separation of patient survival in male recipients, so the green line, and in female recipients, the blue line, with males having a median survival of about 82 months after kidney transplant, and females in this older cohort having a median survival of about 131 months. So, this is Europe. These are older patients. This is obviously not very generalizable to the Canadian context, But actually there's data out of Ontario that shows that there actually remains significant gender and or sex-based differences in 10-year patient survival after kidney transplant, with females expected to survive about 77.9, 10-year survival in females about 77.9%, and in males 73.5% 10-year survival, and these are significantly different. So, you know, it looks like men are more likely to die after a kidney transplant. And what does this mean for us? Well, when we think about mortality risk in the sex-based mortality risk, it's important to think about that in the context of what's going on in the general population. So in 2018 in the United States, a man was expected to live 76.1 years, whereas a woman was expected to live 81.1 years. This is similar in 2022 and similar to what's seen in Canada. If we look at changes in male and female risk of mortality over time, you can see that for both US males and female, in both the United States and in Canada, the male risk of dying at any age is higher than the female risk, including in the reproductive age. So, you know, we see higher risk of mortality post-transplant. Is it simply that we're seeing, you know, higher baseline risk of mortality in the general population, people get a transplant and they remain at higher risk, or is there something else going on here? So in order to really identify how kidney transplantation is impacting patient survival, it's important to examine excess mortality. And when we think about excess mortality, what comes to all of our minds likely is COVID-19, because this has been in the media talking about excess mortality. This is data, again, this is COVID-19 data, but just to make a point, this is data out of Ontario, looking at baseline cremations over the 2 years prior to COVID-19. Total deaths over this early COVID-19, early pandemic period is the orange bar. And then in yellow, the number of cremations during COVID-19 that exclude COVID-19 deaths. So we have some baseline degree of death, we have COVID-19 death, and then we have additional deaths above and beyond that, which is the excess mortality. But we can use this principle to apply to kidney transplantation as well. So what if we want to look at the relative risk in males versus females, again, in the baseline population, acknowledging that at every age over the lifespan, males are higher risk of mortality than females. And of course, that difference changes over time, but at every period, men are higher risk than females for dying. And how does that compare to kidney transplant world? So if we look at the expected hazard ratio for death in males versus females in the general population, and again, that's going to change over calendar year and by age. And then we look at the excess hazard ratio for death in male versus female transplant recipients. So say in the general population, this is not true, but say in the general population, the hazard ratio for a man dying at any period was 1.28. If the hazard ratio in the kidney transplant population for men versus women dying is 1.28, this would suggest that there's no excess risk. And ultimately what we're just seeing is kind of the marching through increased male mortality bias that's observed in the general population. However, if the hazard ratio is more than 1.28, this would suggest that men are actually experiencing even more mortality risk after a kidney transplant, perhaps greater sensitivity to cardiovascular risk or the immunosuppression. And if the hazard ratio is less than 1.28 once someone has a kidney transplant, this would suggest excess risk in female patients who have a kidney transplant. So there's data out of Australia and New Zealand that was just published in 2021. Demonstrating the cumulative relative survival. In Australia now, they're looking at this is time after your first kidney transplant. And what you can see is that actually in Australia, despite a higher risk in male patients in the United States and in Canada, in Australia, it's fairly similar. So you get a kidney transplant and your survival is overall fairly similar if you're a man or a woman. However, because there's this increased baseline risk in the general population in men, actually seeing a similar mortality rate in males and females after a kidney transplant would suggest that women are actually being disproportionately impacted by kidney transplant and are actually losing more years of life than their male counterparts are with a kidney transplant. So this same study demonstrated the years of life lost after your first kidney transplant were far greater if you're a woman than if you're a man. And the earlier you were transplanted, the more years of life were lost, compared to if you never developed kidney failure and you just remained kind of on the straight and narrow with the general population. So this paper came out, and it's actually a very good and very interesting paper, but I must say I was a bit disappointed to see it come out because we've actually written the same paper that's just going in, being submitted this week. However, our paper is also looking at, again, not just the overall risk in males versus excess risk in males versus females, but again, taking into consideration the donor sex and taking into consideration the current age at which the death happens. And ultimately, what I'll tell you is that what we have shown is that the overall excess mortality following a kidney transplant really sort of parallels what was seen for graft failure rates. So there's an increased female excess risk if you have a male donor kidney that's highest in earlier ages, but really no excess mortality if female recipients receive a kidney from a female. So that study is ongoing, and hopefully it will be in print in the next couple of months. So what I wanted to highlight is really that I think our understanding of the role of sex and gender in transplant outcomes is evolving. And I think this picture really highlights where we're at. This is a picture of Pluto in 1994. This is the best we could appreciate of Pluto as this kind of pixelated image. And 25 years later, we're able to really see the granularity of what's going on with this planet. And I think the same thing is happening with outcomes related to sex and gender in kidney transplantation. So in summary, sex and/or gender-based outcomes after transplant are complex. Younger female versus male recipients are higher risk for graft loss if the donor is male, but not when the donor is female. And donor sex, recipient age, and donor-recipient weight pairing all appear to impact those results. So let's talk about outcomes in transplant patients who develop COVID-19. So we know that women, at least in the general population, have better outcomes after COVID-19. In the general population, male sex is strongly associated with mortality from COVID-19, particularly so early in the pandemic. The case fatality ratio, again, earlier in the pandemic, was 1.4 to twofold higher in men than women, or males than females. However, whether male sex is a risk in solid organ transplant patients with COVID-19 is far less clear. So to investigate this, we use data from the National COVID Cohort Collaborative. This is an electronic health record repository funded by the NIH and NCATS that collects data from 75 centers in the United States on people who test positive for COVID-19. And this is from the end of March, at which time there was about 4.5 million COVID positive patients, but it's now closer to about 6 million positive COVID cases. So using this data, we were able to identify patients who developed COVID-19 and then look at outcomes that occurred in the 90 days after their COVID-19 diagnosis. The outcome we're looking at here is major adverse renal or cardiac events as a composite. So this paper looked at outcomes prior to the Delta wave and prior to really sort of more ubiquitous vaccination. In the non-solid organ transplant population, or the general population, we had about 2 million patients who developed COVID-19. And what you can clearly appreciate in this figure is that the risk is dramatically lower in female patients than in male patients. And that risk is even lower in younger female patients. So conversely, if we look at about 11,000 patients with a solid organ transplant and the risk of developing a major adverse renal or cardiac event after diagnosis of COVID-19, you can appreciate pretty clearly that that risk is very attenuated in female versus male recipients. Perhaps there's a slightly lower risk in females than in males. And of course, the confidence intervals are a bit wide here. If we had more people, we might be able to see significantly lower risk of MARS in females than males who develop COVID-19. But absolutely, I think you would all agree that the risk appears to be attenuated. The sex-based risk appears to be attenuated. So if we look at a few other outcomes, for example, MARS, mortality, MACE, AKI, and COVID severity, defined as need for hospitalization, again, in the 90 days after COVID-19 diagnosis, you can see in the general population here again, for each outcome, females are dramatically lower risk than males. Conversely, if we look at the same 5 outcomes after COVID-19 in the solid organ transplant population, again, it's pretty striking the difference that's depicted here. So yes, females are perhaps slightly lower risk than males, and significantly so for the outcomes of MARS or mortality when we look at all age groups together. But clearly the benefit of being female is attenuated if you have a transplant. So with a bit more granularity, if we look at now those same 5 outcomes, but stratified not just by sex, but also by age category, you can appreciate that in the non-solid organ transplant patients who develop COVID-19, 90-day outcomes, each of these 5 outcomes in the 90 days after COVID diagnosis are significantly higher in male than female patients within every single age category, except the outcome of needing hospitalization in young female and male patients. That's the only period whereby there's no increased risk in male patients compared to female patients. And what you can also very clearly appreciate is that risk is dramatically increased with advancing age. Now, conversely, if we look at the solid organ transplant population, what you can appreciate pretty immediately is that really in no specific category is male sex higher risk than female sex for any of these outcomes. And although perhaps there's a slight increase in the risk of each of these outcomes with advancing age, it's quite attenuated compared to what is seen in the non-solid organ transplant population. So for example, the highest risk in solid organ transplant patients for mortality is in males over 65 years of age relative to younger males, with a hazard ratio of 5.82 in solid organ transplant recipients, but that's compared to a hazard ratio of 17.38 for older males versus younger males in the non-solid organ transplant population. So I think this figure is really striking, and it really highlights the fact that in solid organ transplant patients, the sex-based risk and really the age-based risk is quite attenuated compared to what's observed in the non-solid organ transplant population. So in non-solid organ transplant, males have a significantly higher COVID-19 mortality than females. This is believed to relate to inflammaging, which is a decline in adaptive immunity and a dysregulated activation of the innate immune system with advancing age, which is like dramatically more prominent in older males and is associated with an increased risk of cytokine storm and thereby COVID-19 related death. Solid organ transplant males with COVID-19 have an increased risk of MARS and mortality overall compared with females, albeit to a far lesser degree than what's observed in the general population. And the thought here is that perhaps maintenance immunosuppression differentially impacts males and females with COVID-19. For example, in the general population, we know that females have better antiviral clearance than males on account of increased immunity. And so perhaps immunosuppression mitigates that relative immune benefit in females versus males when infected with SARS-CoV-2. And perhaps in males who are at increased risk of cytokine storm, this immunosuppression reduces the exaggerated immune reaction to COVID-19. Now, this might be suggested by results of the recovery trial, which I'm sure you're all familiar with, looking at hospitalized COVID-19 patients and the benefit of dexamethasone on 28-day mortality. This is from the supplement, and if you look at the impact in men versus women, although ultimately this trial was obviously not powered to look at a sex difference, and when we look at these results, clearly the confidence intervals in men and women overlap, and the chi-squared value is not significant. So ultimately, there is no appreciable sex difference by sex, sex difference here in terms of benefit and response to dexamethasone. With that caveat, what you might appreciate is that men appear to have a significant response to dexamethasone, and perhaps that there is no significant benefit with women. Now, this study was obviously underpowered to look at the sex difference, and women only made up 36% of the entire trial. So of course, we can't say anything definitively about this, but it does give you pause, especially in light of what I'm telling you, that immunosuppression seems to differentially impact outcomes in solid organ transplant patients in men and women. So in non-solid organ transplant patients, sex differences were most pronounced in the youngest or reproductive age strata, followed by mid-age, and finally by the oldest group. However, age did not impact sex differences in those with solid organ transplant. And what I hopefully have been able to demonstrate is that when we look at changing risk by sex in different ages, we need to be thinking about sex hormones. And so there was a study that came out examining exactly this, hormone replacement therapy in COVID-19. And it showed that if you're a postmenopausal woman prescribed exogenous estrogen versus not prescribed exogenous estrogen, your odds ratio of dying after COVID-19 was significantly reduced at 0.47. Another study that I was excited to see, but disappointed to see, because we are just finishing the same study, looking at hormone replacement therapy in the general population versus in transplant patients, because we had the same thought. Hormone replacement therapy is felt to stimulate your immune system. Maybe you're going to see benefit in the general population and less benefit in the transplant population. And in fact, that's exactly what we see. Again, looking at these familiar 5 outcomes after COVID-19 diagnosis in male patients on testosterone supplementation and female patients on either estrogen or progesterone supplementation, you can see that hormone replacement therapy seems to minimize your risk of each of these 5 outcomes in the general population. Comparatively, in patients who have a kidney transplant, again, obviously there's small numbers of kidney transplant patients who get COVID, who are on hormone replacement therapy. So our confidence intervals are very wide, and this is just very preliminary data I'm sharing with you at this point. But certainly you can see that it looks that at least in women, the benefit of hormone replacement therapy is probably not quite what is seen in the general population. But of course, this needs more investigation. So ultimately, hormone replacement therapy seems to lead to fewer adverse outcomes after COVID-19 in non-immunosuppressed male and female patients, perhaps on the basis of stimulating the immune response, but there is no benefit in transplant recipients. Now, is that because we're giving you hormone replacement therapy and supplementing your immune system, but we're really blocking that benefit with the immunosuppression that you want? Or is it simply the small sample sizes? This study is sort of a work in progress. And I think when we rerun the data with bigger numbers, we might be able to answer that question. So in summary, Female solid organ transplant recipients are lower risk for MARS and mortality after COVID-19 than males. And sex-based COVID risk is very much attenuated in solid organ transplant patients versus what's observed in the general population. So before I wrap up, I just wanted to talk about one more thing. So we know that women historically are underrepresented in clinical trials. I just showed you this exact slide suggesting that, yes, absolutely, technically there is no difference between the dexamethasone response in men or women in the recovery trial. But again, we have to take pause and think, it makes sense rationally why men might have a better response to dexamethasone than women. I actually wrote about this in an op-ed after the recovery trial came out. Again, stating very clearly, we can't make any definitive conclusions based on this, but it's something for us to think about. And it actually was not well received. People were very unhappy with me for going against the p-value and the confidence intervals, which I understand, but I think it's something we need to think about. So since then, just in 2022, there was a publication in Nature Medicine, actually done by a critical care team out of Calgary, that showed that if we look at COVID positive cases in Alberta, and we look at our ICU mortality rate in the era prior to dexamethasone, in females, the yellow bars, and males, the green bars, and then we look at subsequent ICU mortality after dexamethasone has become standard of care, you can see that men had a significant reduction in their ICU mortality compared to women who really had no difference in their mortality over time. And overall, ICU mortality remained unchanged amongst COVID negative cases. So this came out in the Calgary Herald. Study shows steroid therapy for severely ill COVID-19 patients has little to no benefit for Alberta women. A number of similar publication media highlights. And a quote from the corresponding author is, currently, it's possible that the mainstay therapy for severe COVID-19 that we're giving everybody is only benefiting half the population. And this is a big problem. And, I don't think we can definitively say that dexamethasone does not benefit women. Absolutely, that's not the point I'm trying to make. What I do want to highlight is that we started using dexamethasone in June of 2020, and it's now June of 2022, and we honestly do not know if dexamethasone benefits women who have COVID-19. And I think that's the point I'm trying to make. Now, just to elaborate on that a little bit, in 2016, there was a campaign that came out talking about diversifying women in clinical trials. And the aim here was to try and encourage recruitment of women in clinical trials and to try and get women to actually want to be included in clinical trials. This is sort of a big area in cardiology literature, the participation to prevalence ratio. And you can look at the participation of any given subgroup of patients. But in this case, if we look at the percentage of women in a trial divided by the percentage of women with a disease in the general population, that gives us the participation to prevalence ratio. So by that, I mean, if of all people who have diabetes, 49% of people with diabetes are women, then in theory, 49% of people in the trial should also be women. And a PPR, or participation to prevalence ratio, of 0.8 to 1.2 is considered comparable prevalence and good representation. Now, we don't have any clinical trials really in transplantation, any large-scale clinical trials in transplantation, but since 2016, I think all of us can appreciate that there's been an onslaught of landmark cardiorenal therapies that have been emerging. SGLT2 inhibitors, GLP-1 receptor agonists, non-steroidal MRAs that have had really life-changing impacts on our nephrology patients. So what I wanted to do is, since 2016, this campaign came out to try and include more women in clinical trials. So I looked at the 14 papers examining these three kind of practice-changing drugs that were published in the New England Journal since that 2016 campaign. And the thought here was that, perhaps in this modern era, there's going to be more parity in terms of enrollment of women in these clinical trials. Now, what you can appreciate is that this is looking at PPR, where 1 would be exact prevalence in the general population represented in the clinical trial, with a score of less than 1 meaning more men are in the trial, and a score of more than 1 meaning more women are in the trial. And what you can appreciate is that very clearly women are, again, being underrepresented in these clinical trials. If we look at the pooled analysis using meta-regression of each of these kind of therapies, you can see that the PPR of GLP-1 receptor agonist is 0.72, 0.56 for MRAs, and 0.7 for SGLT2 inhibitors, with really only one trial out of these 14 having a PPR that meets, again, the target that's proposed of more than 0.8. So ultimately, women remain underrepresented in landmark clinical trials for emerging cardiorenal therapies. Why is that? Is it that we're not approaching women, or is it that women are declining enrollment in these trials? And then importantly, does this matter? I'm not saying that we should be delaying trials to try and aggressively recruit women and postponed completing a trial by several years. I truthfully don't even know if it matters if there's no real hypothesis for why women might have a different mechanism or a different response to a given therapy. But this is just kind of a peek behind the curtains of where my mind is going and kind of some of the investigations we're starting to do. So in conclusion, I hope I've been able to convince you that there are sex and or gender differences in access to kidney transplant, outcomes after transplant, outcomes in patients who have COVID after transplant, and then in participation to trials. And then in conclusion, I believe many of you have seen this quote before. It's, here's to strong women. May we know them, may we be them, may we raise them. And I would add, may we transplant them. And then additionally, may we study them. And with that, I would be very happy to take any questions. Thank you so much for the opportunity to speak here. Speak to you. I'm very honored to be here. And my email address is in the top corner. And if anyone has any interest in sex and or gender studies, please reach out to me. I'm always looking for a collaboration. And with that, I can't see any of you, so I'm going to shut down my screen and hopefully see you. Hopefully you're there.
Yes, we're still here. Awesome. Thank you. That is a wonderful overview. And personally, you know, my understanding of sex and gender was sort of like that 1994 Pluto pixelation, and so this is dramatically better after this talk. So, you know, if anyone has questions, feel free to put your hand up or just unmute yourself and ask, but I can start the ball rolling here. I'm not a transplant nephrologist, as a disclosure, but you know that sex and gender differences in especially the sort of, you know, weight and age aspect is fascinating. Has anyone thought about, and I know this will get even more complicated, we have so many algorithms on, you know, PRA and ECD, DCD and all that. Has anyone thought about, you know, matching that when we are doing the allocation?
Yeah, thank you for that question. So I think that's really important. And I think a really important point that I have to make is that, no, I don't think we should be, I don't think that we should be considering sex or gender allocation specifically. There are so many factors at play when we look at outcomes after kidney transplant. Sex and gender is just one that I have a particular interest in, but age plays a role, you know, weight plays a role, HLA plays a role, and then there's all these additional things that have nothing to do with the donor, like how long have you been on dialysis, what are your comorbidities? And so I think there's so many things at play that if we start like teasing out specific allocation rules where we say, you know, we're going to give a male kidney to only males and a female kidney to only females, we're really going to disadvantage populations of patients, and we're going to leave people on the wait list longer than they already are. And so I would say, no, I hope that people would not start allocating kidneys in this world where we have a finite number of kidneys. Maybe in, you know, if we start having pig kidneys or whatever, if we have an abundance of kidneys, then yes, maybe that's something to consider, but not right now.
Yeah, and we may need research on male pigs versus female pigs. No, I'm kidding. Dr. Noel had a question. I'm sure he knows this field way more than me.
Hey, Amanda, thank you. That was really good. Well, about that last question, that was well, I think I don't have the exact numbers, but I think there's far more male deceased donors anyways, and the flip is true for living donors. So that may, you know, negatively impact female recipients on the deceased donor wait list if we went to that. But my question was back to the trial, the last stuff you had about the trial, which is quite interesting. Most of the well done trials will have a figure 1 with the declines. I'd have to look to see if there was anything about characteristics about sex and gender, or is that something you might be looking at, contacting, you know, some of these authors that had these big studies to see if you could get that simple data about who was approached and who was declined, because I think that is really an important aspect of this area.
Absolutely. Thank you so much for saying that. So actually, we have done that. So I looked at the figure 1s for all of those 14 trials that I showed, and none of them include the sex of the people that were approached, but absolutely that's what we thought as well. And so right now I'm sort of, we've written a draft paper and we're trying to now get that additional information. So we're planning to reach out to the corresponding author for each of those 14 papers. I don't know that they will want to hear from little Amanda Vinson, but we're going to try to get that information to find out who was approached. And, you know, there are other trials, for example, Pexivas. I don't know Mike Walsh, but I know he might be more approachable. And so I was wondering about not particularly these trials, but trials that maybe I don't really know him, but I know people who know him who could maybe reach out for that information and kind of bleed the network in that respect. So certainly it's something that we are trying to do. And thanks for bringing that up. Yeah. sorry, I was just going to add that there is literature, again, out of cardiology trials, because cardiology has so many more clinical trials than we have, that women actually often decline being involved in clinical trials because, again, generally at a population level, and generalizing, women are more risk adverse and don't want to be involved in experimental therapies. So it's very possible that we're trying to recruit women, but really aren't doing a good job of it because women are not wanting to be involved. And again, that's something we just need to identify so we can counter that with potentially education and discussion.
True.
And the only other thought that came to mind is there's a lot of, especially of women of childbearing age, there's a lot of risk around drugs and all the, requirement for a pregnancy test and all this sort of stuff, which may impact participation.
That's a very good point.
Yeah, and also all these social aspects, right? You have all these visits that are required, research visits, and with busier lives. And I think there's a lot of push now from what I've seen is that we have to make the trials also accessible. We can't use that as an excuse saying, oh, this is too difficult for you. We have to make it, we have to put in more effort to make sure that we provide equity for participation as well. Yeah, Dr. Karpinski.
So I'll just comment, there's a question in the chat box maybe to do first, and then I do have a question. But Dr. Davis is asking, does anyone know if there's a gender disparity in the yes or no answer locally? Jan, did you mean locally if people are being asked to contact for research studies? And I guess maybe related to that, is there any publication quality, or we have standards for how studies are performed and publications are reported in terms of what information must be included. Is there any standards for including characteristics about people who are asked to participate and decline?
You mean in terms of a trial when we approach people and then look at the percentage of people who are declining, whether they're women or men or what other characteristics? As far as I know, there's not any standard where we have to where investigators need to disclose or report who's declining involvement in trials. And certainly for all of those 14 studies I reported, I went through every page of the supplement and everything, and there was nothing about who declined to participate. So I don't think so, but absolutely it's a really important question. And actually, I think potentially, it could be an opinion piece that could be written talking about maybe we do need to include that, looking at who's declining participation, so that we can at least prove that if it's the case that we are approaching people equally.
I don't know if Greg put his hand up. I don't know if he's got it.
No, I just want to say, Amanda, David Moore, who is one of the leaders of Consort, is here in Ottawa, and so if you wanted to address that with him, he's very open to these sorts of discussions, and he may be able to bring it forward to the next Consort meeting. So that's probably an important first step, I think, especially given that was it the FDA that put on that push for getting women into trials. It would seem to be a natural step to start gathering some data. Yeah,
that would be wonderful. Yeah. I love that. Thank you.
So I think Jan's question was whether there's any if the local researchers know if there's any gender disparity. So folks know, maybe you could pop that in the chat box for Jan. My question was about the impact of caregivers. I remember way back when there were studies looking at, living donors in kidney transplantation, and, men are more likely to get a living donor, and often it's a woman. And so when you look at these sex and gender disparities, I wonder how much, or if there's any data on how much is related to caregiver and caregiver support. And I'd be interested, and there's certainly data in terms of caregiver burden and support for peritoneal dialysis as well. I don't know if any of my PD colleagues have know more about that. But anyway, and I don't know do you have any answers, or is that something you're looking at in your qualitative study?
Yeah, thank you for bringing that up. So I don't actually know if there's any literature in kidney transplant per se. We do know that there is generalized literature, as you're alluding to and referring to, about having a female caregiver at home has shown better compliance with medications in general and better health outcomes in general than if you have a male caregiver at home. But I don't actually know if that's been studied in kidney transplantation. Certainly it's something that should be studied in transplantation if it isn't already. And I'm sorry, I don't know the answer to that, but I think it's a really good point that should be studied if it hasn't already been.
Thanks. And do you know if there's any data on peritoneal dialysis?
I'm not sure.
Yeah. Okay. Thank you.
Sorry.
It's something. Oh, we do have more questions. Mark.
Hey, Amanda. Thanks very much, and congratulations on all these major publications in the last couple of years. You're fairly rocking it there. The BMJ paper, the Delamata paper, I reviewed that paper, and at the time I was like, I was blown away by those findings, and I said, like, this study absolutely needs to be published and has to be reproduced in another jurisdiction. We need to know whether this is real, because honestly, everybody should just look at that paper. Like, it's startling, the differences, and not just in transplant, but also in dialysis. So to Yolanda's point, they did actually go back and look between like hemo and PD and transplant. And I was trying to, at the time, I was like, why would this be? Like, what is the big determinant? And at that younger age, the things that I thought about were, a higher predisposition to autoimmune disease and complications of autoimmune disease, and then obviously pregnancy. And they did have cause of death in that study, and somewhere buried in the supplement, there was like some signal for like lupus, but like not enough to explain this massive chasm between the two. But I mean, are you able in your study where you're looking at a similar thing to try and tease out like what actually might be going on to explain it, rather than just, yes, we're also seeing this big difference?
Yeah, so I was honestly very sad to see that study published, because our paper has already been written, but it actually I think it's a really hard thing to wrap your head around, this excess risk, and where our paper is looking at excess risk by current age, stratified by donor sex. It's I think it's unfortunately gonna be a hard one to get published because it's so kind of complex. So this might actually help us in a way. But what we show is that in younger age, when the donor's female, actually there's no increased excess risk. So again, that male mortality bias is preserved if you have a female if your donor is female. And so really, if you have a female donor, no difference. If you have a male donor, though, there's increased excess risk that's exaggerated in the younger age groups. And the thought, it parallels exactly what we see for death sensor graft loss. And we know from other studies that one of the major predictors of death after a transplant is graft loss. So there's a huge increase in your risk of dying after your transplant fails. And so what we're hypothesizing is that in this setting, again, just a hypothesis, but what we're thinking is that a lot of the excess mortality that we're seeing in women who get a kidney from a male is the increased risk of death sensor, the increased risk of graft loss that's then driving an increased risk of subsequent mortality.
Yeah.
But there are like, so many moving pieces and so many ways to think about it, because it's not just the biological implications of sex. We also know that women, again, generalizing, but women are generally more compliant with medications. They're more compliant with seeking healthcare providers or reporting if they have a medical issue than men are. And so there's a lot of things at play here, but ultimately the increased risk we think is related to that increased signal of graft loss.
But the difference in dialysis was also like really striking at younger age. So
yeah, I'm not sure.
There's more to it, obviously. Yeah.
You should have reviewed that paper. Sorry, go ahead.
Oh, sorry. I was just going to add the other thing that we're finding is that, so these are relative risks, and the absolute risk of dying when you're young is so low that one additional person dying brings up your relative risk dramatically. And so we actually in our paper have looked at the crude risk of dying by age category and the absolute, the crude kind of risk of dying by age category, and then the relative risk. And, we're seeing, in the younger age categories, combining data from the ANS data, SRTR and the SRTR, in people who are less than 12 years old, we're seeing like 20 deaths, and so it doesn't take much to really impact that relative risk. So that might be playing a role as well. Not sure about the dialysis data so much.
Yeah, and if I could ask the last question, we only have a minute left. Part of, if you talk about change in practice, these barriers that you've talked about, especially in the referral, which is where, I live in the referral ward where I'm referring patients, and maybe we are biased. Is there any thought about what kind of intervention would be useful here? I guess, even making us aware of our biases may be the first huge step. and maybe that's all you need, but probably not. Yolanda's shaking her head. We need something more. I mean, you could have more objective ways of referral where it's not the physician who makes the decision, but is there any thought about designing an intervention to see how we can change this?
Yeah, thank you so much for the question. So I don't know the answer, but I do think it's going to depend on where the biggest barrier lies. So if it's different, if it's patients not advocating for themselves or being like, I have one female patient who says she does not want to be on the transplant list because she doesn't want to take a kidney from another person. And so if we can identify what the issues are, that's just like one anecdotal story, but if we can identify what the issues are, then we can maybe target education and engagement, patient engagement to try and overcome that. But I'll tell you that since I've gone on this like tirade about identifying we've had such disparities in referral in our own program, I've been basically banging the drum at our own center, and referral rates in women have gone up as a result. And so I'd be interested actually to see, since I've basically said, guys, I think we're disadvantaging the women in our practice. Referral rates have gone up, and so I do think being aware is one step. It's not the only step because there are a lot of factors at play, but I think we just need to really have an understanding of what the problems are so that we can challenge that. Another thing, and I know we're running out of time, the other thing I was going to suggest is like a separate issue altogether, but Nova Scotia has a presumed consent for like an opt-in for, sorry, an opt-out for organ donation. So unrelated to that, but what about an opt-out for transplant referral? So basically everybody is referred unless we absolutely have something in the chart that says this person is not for referral. Of course, that takes a lot of resources, and we have 3 transplanters, so we would never be able to sustain it in Nova Scotia at this point, but like it might be a way to I've never heard of a country or a center doing that, but I think it could be a potentially innovative way to ensure that everybody's referred unless we're pulling people off the list intentionally.
Yeah, so Yolanda had a point that just being aware doesn't seem to help necessarily, and your experience may be short term, right? It'll be interesting to see if it stays for long term. And the other comment is very interesting, the opt out. I remember when we had a previous EMR before we had Epic. In nephrocare, we had to, I remember as a dialyzer, I had to evaluate every single patient. And if they were not a transplant candidate, I had to say why they were not a transplant candidate. And now it no longer exists, because we have something called Epic, which is, truly epic. Now, the onus is on us to, decide that this patient has to be referred. So it might be interesting to see locally, whether our rates were different in waitlisting when we had this deliberate, right? Every patient has to be evaluated. It will still not take care of some biases, right? I may still think, oh, this patient is frail and, she should not be sent. But that may force us to make that, at least make that cognitive decision. Yeah.
I'll just quickly add that we're going through and auditing every single chart that was not referred for a kidney transplant and looking at what's been written. So we don't have an opt-out procedure, but basically if someone's not referred, we have to say why. And I would say 95% of the charts say medically unsuitable, and that's it. And so of course that's not really a clear reason why. We have to actually identify why. And so actually having to pick a specific reason, like this person has severe cardiovascular disease or whatever it might be, might also drive referral rates and reduce the bias. Fantastic.
That was a really great talk, as well as a really fruitful discussion. Thank you again, Amanda. This is all virtual, so we could get this done. But hopefully, we'll meet. Your TED talk was also virtual, but at the next CSN, I'm sure we can chat in person.
Yes. Well, thank you so much, everyone. I'm very happy to have been given this opportunity. So thank you.
Bye-bye.